You're watching the award-winning American Health Journal.
Almost everyone with diabetes eventually develops signs of retinal damage. The National Eye Institute estimates 40 to 45% of all diabetics are affected by diabetic retinopathy, and 24,000 of them go blind each year. When we visited Dr. Kent Small at the Macula and Retina Institute, we asked him to explain how diabetes affects the retina.
Really what we're talking about is how diabetes affects the blood vessels throughout the entire body. Because basically chronically elevated blood sugars, which is what diabetes is, damages the lining of the blood vessels throughout the entire body. The retina is one of the few places in the body where we can look directly in there and see that damage going on. And so just a little bit of damage, the retina is so fragile, it's such a fragile tissue, just a little bit of damage to the blood vessels can wreak havoc. The blood sugar damages the blood vessels in a couple of different ways in the retina and throughout the entire body. And actually, by the time we're starting to see damage in the retina, your internist can pick up damage in your kidneys, in your feet, in your nerves, and elsewhere in the body. So what we see in the retina is kind of a barometer of what we see going on elsewhere with the blood vessels throughout the entire body. But the damage that occurs initially usually is just some mild damage to the lining of the blood vessels, which then the blood vessels don't hold the blood and the serum in, and it kind of leaks out into the tissue and causes the tissue to swell. And that would be diabetic macular edema. Edema means swelling. And that is one manifestation of diabetic retinopathy, or how diabetes damages the retina. Sometimes, and particularly with younger age onset diabetics, the blood sugar damages the blood vessels so badly that the blood vessels just close off entirely. When that happens, the retina tries to heal itself by growing new blood vessels, which sounds like a good thing, except these new blood vessels are very fragile and they break and they bleed. And when they bleed, it can be a very catastrophic bleed, very sudden cataclysmic bleed. The type 1 diabetics, the younger age onset diabetics, tend to get the full closure of the blood vessels and the blood vessel growth, which is we call proliferative diabetic retinopathy, proliferative meaning growing. The type 2 diabetics, the later age onset diabetics, tend to get more of just the milder damage to the blood vessels where the swelling occurs in the macula, in the retina. The big issue is, there's 18 million Americans with diabetes. That incidence has tripled in the last 30 years because of our incidence of obesity that's been increasing. More importantly, about 5 million of those people don't even know they have diabetes. The risk of diabetic retinopathy and the risk of vision loss from diabetic retinopathy can be decreased by 95% if picked up early and managed and treated properly.
Is there any way to prevent diabetic retinopathy?
Managing and controlling blood sugar, blood pressure, weight, and cholesterol improves your odds and basically decreases the incidence and progression of diabetic retinopathy. So good systemic care of the diabetes is of course important. Once diabetic retinopathy has developed, the standard treatment is still laser photocoagulation, basically taking a laser and trying to seal the blood vessels from leaking and bleeding. More recently, there's been studies showing that injecting medications into the eye, such as steroids or anti-VEGFs, anti-vascular endothelial growth factor medications, also help to control diabetic retinopathy and improve vision in some cases. Every diabetic, whether they're type 1, type 2, should have a full, dilated, comprehensive eye exam every year. The findings of diabetic retinopathy, when they're picked up early, are very easy to treat and manage and to be able to maintain good vision. The people that get into trouble, the people that go blind from diabetic retinopathy, are people who don't get in and get their eye exams and don't take care of themselves and aren't compliant with their medications and don't follow their internist's orders.
And what are the treatments for diabetic retinopathy?
First is laser photocoagulation treatment, where you seal the blood vessels. Sometimes in combination with injecting steroids or anti-VEGFs in the eye. And if those don't succeed, the next step up usually is a vitrectomy, surgery, going into the back of the eye, removing the vitreous jelly. And a lot of times, particularly when these new blood vessels have grown and have broken and bled, it causes a lot of scar tissue that can pull the retina off and detach the retina. So going in with surgery and removing that blood, removing that scar tissue is often beneficial. That's a vitrectomy surgery.
We'd like to hear from you and what you think about the American Health Journal. Any topic suggestions or comments about our doctors, email us from our website, thedoctorshow.com, or call 1-800-303-3200.
During our program, Dr. Small has mentioned floaters in the eyes. We ask him to define floaters for us.
What are floaters? Well, the vitreous jelly in the back of the eye is about 99% water and 1% little collagen fibrils and some globular proteins. And those structures early in life are very clear. As we get older, and it's not really an aging degeneration, I like to tell my patients, a lot of them say, well, is this because I'm getting old? I said, no, it's really an issue of exposure to time. There's a subtle difference there. Nonetheless, with time, these proteins start to clump together. And eventually, in 80% of us, the jelly peels away from the retina, from the back of the eye, and collapses in on itself and makes all these little clumps of gel. The light coming in the eye strikes that gel, it scatters the light, which casts a shadow on your retina in the back of the eye, which we then perceive as little black spots, bugs, worms, and those are the floaters. Most floaters are benign, although annoying. And some patients complain quite bitterly about their floaters. But most of them are benign. What we worry most about floaters and flashing lights is it can be associated with a retinal tear or retinal detachment. So anytime anybody has a new onset of a shower of floaters or flashing lights, it's imperative that they get in and get a good, full, dilated eye exam to check the retina to make sure that the retina is secure. Once you've figured out that the retina is secure and not going to detach, then it's an issue of how do we deal with this annoyance?
And what causes flashing lights?
Is basically the retina is a real big phototransducer. It has no pain fibers, cold fibers. So if you pull on the retina or do any kind of mechanical stimulation of the retina, it generates what we perceive as little flickers of light. And typically they're noted at bedtime or in dark environments. Most commonly, they're probably going on throughout the day, but it's being bleached out by the ambient light. So the flashing lights indicate that there's some kind of mechanical stimulation of the retina. And typically when associated with floaters, it's the vitreous jelly that's peeling away and pulling gently on the surface of the retina. And again, as long as it doesn't pull a hole or a tear in the retina, it's not a medical problem per se. It's more of an annoyance. The flashing lights usually subside within a month or two. Floaters, if they're just benign floaters not associated with a tear in the retina, they generally get better. But over 6 months, 12 months, it's a very slow process. Most people eventually stop complaining about their floaters. Some of them dissolve. Some of them will drift over to a part of the retina where they don't notice it as much. And in some of it's just your brain gets used to it and learns to tolerate it.
Finally, we ask if there is any way to treat floaters in the eye.
Currently, there's really only one treatment for floaters if they're bothering the patient and interfering with the patient's ability to function and work, and it's surgery. So I usually discourage patients from proceeding down that path because surgery, although it's a very simple procedure, it's a vitrectomy surgery, going into the back of the eye and removing the jelly and the floaters. It's a fairly simple procedure. It's a 20-minute outpatient kind of thing. It is surgery, and it does have risk. So you don't really want to engage in that risk if it's not really necessary, in my opinion. As Mark Twain once said, there's no disease a doctor can't make worse. And to go in after floaters, you could be tickling the tail of the tiger a little bit. So I usually encourage my patients to give a new onset of floaters at least 6 months before they determine that they want to have surgery on them or not.
Join us next time when the American Health Journal brings you more in our ongoing series for your better health. If you have questions about topics or doctors you've seen on this show, you can contact us at 800-303-3200. And now you can get AHJ on your mobile phone. Download our app from ahjmobile.com. Until next time, I'm Roger Cooper for the American Health Journal.